An honor to be here on such an auspicious occasion and historic occasion. I'm a bit overwhelmed, but I'll try and cope. And I fear that after such a marvelous and historic presentation, much of it was in Dutch. But I understood a bit about shoulders and giants. That I understood. But I also appreciated the seriousness with which your organization takes the care of individuals with personality disorder, and it is really that seriousness and that concern that makes both Anthony Bateman and I feel very committed to your group and to feel privileged to be affiliated with it in some way. So that came across from your presentation, and it resonated very deeply with me. So what I'm going to talk about will be very mundane by comparison. I'm going to talk about setting up services for individuals with personality disorder. And it's a different talk from the one I normally give, which is kind of scientific and full of references, and I always enjoy it. Not everybody else does. But, for me, you know, swimming in my own knowledge is just it's a delight. I understand from expert colleagues that this is a feature of narcissistic personality disorder. I choose not to take that too seriously. Anyway, it's so what I'm going to describe is really a situation in the United Kingdom. And any resemblance to characters or persons in the Netherlands is obviously purely accidental. It's entirely our problem across the other side of the channel, if I identify any problem. And I'm sure that any services here function without difficulties, without conflict, without rivalries, without these base human sentiments that trouble us over in England, even in the mental health profession. It's hard to believe, I know. And there's not going to be a great deal of new in what I say, and much of it might seem obvious, but at the same time, I think some of it bears repeating because it's a kind of way of working through things that we know but are nevertheless important. So let me start with some basic epidemiology of personality disorder. In the community, 4 to 10% of individuals have personality disorder. In primary care, it's 20%. In mental health teams, it's 40%, and in prisons, it's 70% of individuals that are affected like this. And this has to be taken into consideration when we design care pathways. Of course, the example of BPD is a very strong illustration with 8 to 11% of outpatients having this diagnosis, and recent community surveys in the United States identified 6% of a community that is diagnosable as BPD. You'll be reassured to hear that in Norway it's less than 1%. So it's clearly just an American problem. But it also indicates that there are very important cultural variants, which I'm sure affect you here as well. About 25% of inpatients in the United Kingdom have the diagnosis. And 9% commit suicide. 10% at any one time have the history. And we know that around 3/4 attempt suicide. In the UK, 80% are hospitalized annually for a brief period. And the average patient stay can be as much as 70 days. More recently, we've identified natural history of BPD that, of course, is quite sobering. It turns out that certain symptoms of BPD, particularly symptoms associated with impulsivity, impulsive features, recover relatively quickly, recover within about 6 years in a large proportion of those individuals. However, interpersonal features, things like aloneness, abandonment, affect storms, relationship storms, dependency, take longer to recover, and affective features, things like hopelessness, anger, anxiety, depression, hardly show any improvement. So it's actually a much more complex picture, particularly because it is these more dramatic features that drive the design of services often, whereas these less dramatic features are more chronic. So, what about service models of personality disorder? Well, basically, there are only about 3 service models. These are the sole practitioner model, the divided functions model, and the specialist teams model. Now, the sole practitioners model is a single mental health practitioner who is the primary treater of an individual with personality disorder. It's a psychiatrist, and we combine their treatment with pharmacotherapy. And basically, we know that this is a dangerous way of treating these individuals. It's useful only for less severe cluster B and cluster C personality disorder, because the basic training that the average mental health practitioner has is unlikely to equip them to treat personality disorder at more severe level. So what can happen in practice out in the UK, not here, obviously, what can happen in the UK is that there is kind of a divided function of individuals who, in combination, feel that their competencies equip them to treat such individuals. So there may be therapists working with a pharmacotherapist or social care agencies, housing agencies. They all have clear roles and responsibilities, and in the UK we have a care plan approach. They may share a care plan, but they are working within a community mental health team, and they might even have a crisis response mode. However, there are major problems with the divided functions model. In the UK, at least, as I said, this is nothing to do with what happens here. In the UK, at least, what we find is that fragmented individuals receive fragmented care. And you have a splitting of treatments with medication, therapeutic alliance, management of crisis, actually sometimes being quite chaotic. Responsibilities, particularly at times of crisis, get very fuzzy.